Okay.
Got it. Okay, so thanks everyone for joining. My name is Chris Dingman. I'm the Chief Commercial Officer for OncoHost and delighted to be able to introduce our speakers this evening. Dr. David Gandara, who many of you know, co-director for the Center of Experimental Therapeutics and Cancer. He's at UC Davis, and I think importantly, this evening, adjunct professor, University of Hawaii Cancer Center, because he is in Hawaii, and which is why I have my Hawaiian shirt on for him. And Dr. Singhal, who's an assistant professor of medicine, also at UC Davis in the Thoracic Medical Oncology Department. So really very delighted to have both of you run through the updates in composite biomarker testing for immunotherapy decision-making in non-small cell lung cancer. So I will hand it over. Dr. Singhal is going to forward slides for Dr. Gandara, and then she will take over with the remaining. And our final slide will be an opportunity for you to provide, ask questions through a QR code as well. And then again, verbally ask questions or put them in the chat. So thank you very much.
Okay, well, thank you. Thank you all for joining us. I'll say aloha because, as Chris said, some of you know I have a part-time job at the University of Hawaii Cancer Center, so I'm here consulting with them this week. I have a shirt that's supposed to be Hawaii, but mine is not actually very colorful. So at any rate, thank you for joining. I'm going to talk a bit about unmet needs in biomarker development. And this, I think all of you know who are on this call, it's very different in development of a biomarker compared to a drug. You know, a drug has a start and it goes through phases, and finally it has a pivotal study, and then, you know, maybe it goes to ODAC, and then all of a sudden it's approved. So 3 hours ago, torlatinib, a bispecific, was approved for small cell lung cancer. So boom, there it was. I learned about this from where I learn all my medical knowledge, which is X, formerly known as Twitter. But I'm just saying that's an event. But for a biomarker, particularly the last few years in cancer, it's hard to know when something is research versus standard of care. So I'm going to be saying what we know about biomarkers for immunotherapy, and then what I think is an exciting new development, a new assay. Next. These are my disclosures. Next. And I start with this slide. This is homemade. I made this myself. There can be no other studies done because I've run out of room, as you can tell from the bottom of this slide. It has about 22 phase 3 trials, first-line immunotherapy, non-small cell lung cancer. The important thing is all but 2 were positive for the primary endpoint, but the trials themselves are very different. There's monotherapy, there's combination with chemotherapy, IO. Sometimes there was a biomarker like PD-L1 or TMB. Sometimes there was not, histology differences. So part of the unmet need is, with so many options for different groups of patients, what does an oncologist do? Next. This is a nice slide that shows that compared to genomic biomarker testing for immunotherapy, there are literally hundreds of potential biomarkers that could be related to tumor neoantigenicity, the tumor microenvironment, or the host microenvironment, or genomics that would predispose that cancer toward immune suppression or evasion. Next. And next. So PD-L1 and TMB are the biomarkers that we use clinically. They are both FDA approved, but we're looking for something better. Next. So a little bit later, Serbi will talk about the main topic for discussion today, and that is a new plasma proteomic assay called PROphet. But first, I'll set the stage. Next. This is a slide that was first presented 10 years ago in ASCO. And what this shows is that regardless of the drug, meaning the PD-L1 or PD-1 inhibitor, regardless of the tumor type, regardless of the setting, that if that cancer was PD-L1 positive, the response rate was higher. If you can advance once. Regardless of all those issues. But in non-small cell lung cancer, we measure PD-L1 in a different way from almost any other cancer type. We don't use CPS, we use TPS. We only look at what's on the tumor surface. And this is problematic. And it leads to misinterpretation of PD-L1. A lot of you know, for example, PD-L1 TPS can be sky high in EGFR mutated lung cancer. That does not mean that it's an immunogenic cancer. It does not mean they will respond to immunotherapy. Next. Of course, if PD-L1 by TPS is very high, like in the Keynote-24 study, it is highly predictive of outcome. Interestingly, more predictive for survival than it is for response rate or PFS. Next. But in essentially every study that's been done, there is a subset of patients with no expression whatsoever, not a single cell staining for PD-L1 that still have survival benefit. Next. And also for long-term outcome, we know that some groups with very low, essentially absent PD-L1 expression, that there is no benefit. This happens to be squamous cell lung cancer in one of the Keynote trials. I'm sorry, this is non-squamous cell lung cancer. Oh, this is actually a combination. It's a combination of both of the studies, that there is basically no difference in overall survival at 5 years. Next slide. Well, what about TMB? Well, we know that TMB actually quantitatively by commercial assays matches very well with TMB by whole exome sequencing. Next, and that's shown there. And that for the foundation medicine assessment of TMB, that it also correlates just as well with response to immunotherapy as does neoantigen load, a more sophisticated way of looking at the functional TMB. And we also know that PD-L1 and TMB are non-overlapping. Next. Next slide. TMB is FDA approved on a fairly pan-tumor basis, based on a fairly small study, Keynote 158, and it's approved using the Foundation Medicine CDX at a level of 10 mutations per megabase or greater. Next slide. There is a problem with TMB, and I've actually shown this in some of my studies, unfortunately, and that is that TMB, while it is predictive for monotherapy with checkpoint inhibitors, PD-1, PD-L1, it loses its predictive value when you take those together with chemotherapy. Chemotherapy, being agnostic, dilutes out the value. You can see in 4 analyses, and this was all TMB by whole exome sequencing in tissue, that for pembrolizumab monotherapy, TMB high correlated with both PFS and OS, but not in either of the studies of pembrolizumab together with platinum chemotherapy. Next slide. Next slide. So that brings us back to PROphet. And I think at this point, I will turn it over to Survi. Thank you.
Thanks so much, David. That was fantastic. And I have to say, I'm not in a place nearly as lovely as Hawaii when I'm delivering this, so hence I don't have my Hawaiian shirt. But I'm lucky enough today to be talking about the background of this PROphet test, this PROphet non-small cell lung cancer. So I'll cover the development, validation, and clinical utility of the test. So before we get into some of the clinical data, I wanted to discuss how PROphet works, which is what's shown on this slide. So if we start at the far left, the researchers collected pre-treatment plasma samples from 500 patients with non-small cell lung cancer who were receiving immune checkpoint inhibitors, and they enrolled them in a clinical trial. PROphet requires 0.2 milliliters of plasma. From that sample collection, deep plasma proteomic profiling was conducted using aptamer technology via the SomaScan assay. Now, while that was being done, in parallel, clinical benefit data were collected for the patients. So patients who had a PFS of 12 months or higher were considered to have a clinical benefit, while those who had a PFS of less than 12 months were considered to have no clinical benefit. The expression level of those various proteins was plotted according to whether that patient derived a clinical benefit. And then based on this, 388 resistance-associated proteins were identified. And each resistance-associated protein is an alert that can either be an on or off in expression. And the collection of those on and off resistance-associated proteins forms this individual resistance map for a patient. And so, for example, a patient who had more resistance-associated proteins on may be less likely to have clinical benefit from the immune checkpoint inhibitor. The machine learning model then infers the likelihood of clinical benefit for each patient based on this individual resistance map. And based on this, the model assigns an overall clinical benefit probability to the patient ranging from 0 to 10, so a numerical score. And that numerical score is then linearly transformed into a positive or negative binary result. One thing I want to mention about the study is this are real world data. So the patients are enrolled in the clinical trial, but the results of this assay is not shared with the clinician or patient. So it's not meant to inform the treatment in this development. The performance then of PROphet is assessed. So the first two figures here represent the assessment of the SomaScan proteomics assay, while the third figure represents the assessment of the PROphet model. So if we start with figure 1 on the far left, each column in this x-axis represents an individual patient. The first 4 columns represent the test being performed by technician 1, and the next 4 columns are the same 4 patients with the same 4 samples being tested by a different technician. For each patient, the different proteins are measured and then repeatedly measured to determine the coefficients of variability, which is plotted on that y-axis. And small values in the coefficients of variability correlate with less noise in the assay. And most of the proteins, as you can see here, have a correlative variability of around 4 to 5%. If we move to figure 2, this compares the measurement of the SomaScan assay to a reference lab. The y-axis represents accuracy rate, where higher values represent higher accuracy. And then finally, figure 3, this is the precision of PROphet. So for each patient sample that's shown in the x-axis, the PROphet model was repeated multiple times on that sample. And the output of that scaled clinical benefit probability from 0 to 10 is shown on the y-axis. And as you can see, for each patient, the model has high precision. This is the analytical validity. We can then look at the clinical validation. This slide depicts the cohorts of PROphet based on the prophetic study in terms of clinical validation. So in the prophetic study, there were 500 total patients. These were split into a development set and a validation set here, shown on the bottom left. We'll talk about these results in a moment. And then separately, the performance was evaluated in a cohort of 529 patients, which we'll discuss in further detail in a moment. But first, I want to talk about that clinical validation. This slide depicts that analytical and clinical validation of the PROphet assay. So I'll start by drawing your attention to this box on the top. This is the clinical validations for patients who are receiving immune checkpoint inhibitors. The figure on the left demonstrates the predicted clinical benefit on the x-axis compared to the observed clinical benefit on the y. And you can see an impressive R-squared of 0.98. This was in a blinded cohort. The next figure, we see the overall survival curve according to PROphet in the validation set. This included 272 patients with all PD-L1 levels that were receiving first-line treatment. And then as you can see on the far right, we see the area under the curve in this validation set with an area under the curve of 0.68. That's patients receiving immune checkpoint inhibitors. There was a smaller cohort of patients receiving chemotherapy, and we can see that PROphet is agnostic to chemotherapy with an R squared here of 0.28. And in this cohort of 85 patients, there was no significant differences detected in overall survival among the patients who were treated with chemotherapy according to whether the PROphet score was positive or negative. And so David talked about PDL1 score and perhaps some of the limitations that we have here. This slide demonstrates how PROphet and PDL1 are largely non-overlapping and independent variables. So the figure on the left demonstrates how roughly 50% of the cases are PROphet positive and 50% are PROphet negative. And if we recall, PROphet is a linear score from 0 to 10 that is transformed to either positive or negative. And we can see that the PROphet positive versus negative is distributed across the PDL1 levels. The figure on the right is plotting the PDL1 numerical score with the PROphet numerical score. So for the first figure, we see the numerical PDL1 TPS on the x-axis and PROphet on the y-axis. And so if we look at PDL1 less than 1%, 0 on this x-axis, we can see that the PROphet scores from 0 to 10 really just span the whole thing. And the same is true if we look at the flip side. So if we look at PROphet 8 to 10, then we can see that their PDL1 scores also span 0 to 100. The figure immediately to the right of that is looking at something similar, but breaks PDL1 into the categorical variables we use of less than 1%, 1 to 49%, and 50% or higher. And we can see again that for each of these categories, the PROphet score is distributed across PDL1 categories. And so I wanted to explore this a little bit further in the context of both PROphet and PDL1. So as this group is very well aware, there's a lot of increasing interest now in combining biomarkers to get better predictive value. So for example, combining PDL1 score and TMB. And in this case, PROphet is not proposed as a standalone test, but instead to be used together with PDL1 to refine the predicted therapeutic benefit from an immune checkpoint inhibitor. And so what I'm showing here are some preliminary results to serve as examples. The box on the left is for patients who are PROphet positive, whose tumors have a PDL1 of 50% or higher. And the box on the right is still PDL1 50% or higher, but now PROphet negative. So if we look at this box on the left, this is the overall survival curve in a real-world cohort. Patients who received immune checkpoint inhibitor plus chemo had no difference in overall survival compared to those who receive immune checkpoint inhibitor monotherapy if they were PROphet positive. That is not true if we look at the PROphet negative group. So in that group, patients who received immune checkpoint inhibitor plus chemotherapy had an improved overall survival compared to those who received immune checkpoint inhibitor on its own. And the immune checkpoint inhibitors being studied here are anti-PD-1 or PDL1 inhibitors. And we can look at this a little in a different way when we look at subgroups. So here we see that the overall survival benefit from immune checkpoint inhibitor monotherapy in patients who are PDL1 50% or higher, in those who are PROphet positive versus negative, is not restricted to any single subgroup. And so, for example, we can look at lung histology. We see a reasonable hazard ratio for squamous. PROphet still correlates with the outcome in squamous, but potentially to a lower degree than it does in non-squamous. But the sample size here is very small, and this needs to be validated in a larger study. That's the TPS 50% or higher group. But we can also look at the other TPS subgroups. So this is the same study, the same outline of a slide that we saw 2 slides ago, but instead of 50% higher, this is PDL1 1 to 49%. And we can see for patients with PDL1 1 to 49% who are PROphet positive, we see an improved overall survival with immune checkpoint inhibitor plus chemotherapy compared to chemotherapy alone on the left. But then for those who are PROphet negative, we see that the patients with immune checkpoint inhibitor plus chemo still have a benefit compared to chemotherapy, but not to the same degree as those that are PROphet positive. And then we can also look at the group that's PDL1 less than 1%. So again, PROphet positive on the left, PROphet negative on the right. And for patients who are PROphet positive, we can see that these patients, again, have an improved overall survival with immune checkpoint inhibitor plus chemotherapy compared to chemotherapy alone. And for patients who are prophet negative, whose tumors are PD-L1 less than 1%, we see generally poor outcomes with our standard of care therapies. And so overall, this slide summarizes how PROphet can be combined with PD-L1 to refine the predicted clinical benefit from immune checkpoint inhibitor in non-small cell lung cancer. Here is a sample report. So it has three main components: the positive versus negative test result, the numerical PROphet score, and then treatment considerations. So as we discussed, PROphet's a binary positive versus negative result, but is actually scored 0 to 10. That is linearly transformed into that positive versus negative result. And so this report also provides that numerical score. And then based on whether that test result is positive versus negative, the report provides some treatment considerations provided. And so now I want to illustrate how PROphet could be used with a patient case. So this is actually my patient. I changed some of the details to help protect the patient privacy. But this is a 78-year-old woman. I called the patient ECOG 1 to 2, depending on the day, former tobacco use, normal labs. She was diagnosed with a stage 1A non-small cell lung cancer, had a lobectomy and a mediastinal node dissection at that time. The final pathology confirmed stage 1A, no nodes involved. TPS was 99%, had a KRAS G12C mutation. He was evaluated by medical oncology locally, recommended to proceed with active surveillance given the stage 1A disease, and also recommended to have that molecular testing. She then relocated a few months later, established care to have her surveillance, and repeat scan showed rapidly progressing bilateral lung nodules. And she's very surprised that she has no symptoms. She gets a repeat biopsy that confirms adenocarcinoma. PD-L1 reported as 96%. KRAS G12C mutations detected. She gets a PET. There's no distant metastatic disease, but she's a brain MRI that shows a single sub-centimeter brain metastasis. And so you don't need to answer this question, but I think of it as a thought exercise. What would you recommend for this 78-year-old woman, ECOG 1 to 2, no symptoms, biopsy proven, recurrent/metastatic non-small cell lung cancer, who had a recurrence within a few months after surgery, adenocarcinoma, high TPS, KRAS G12C. So I just chose, for the immune therapy here, I chose pembrolizumab for ease, but we could easily substitute in any of the anti-PD-1 or PD-L1 inhibitors. So you could do a single agent pembrolizumab given the high TPS. That's like a Keynote 42 regimen. You could do something like Keynote 189, which is chemotherapy plus immune therapy. You could escalate the immune checkpoint inhibitor with an anti-CTLA-4 in addition, like a Checkmate 9LA regimen, or you could choose a targeted therapy. And so we have multiple options that we could potentially explore for this patient. And this patient gets a PROphet test ordered. This is actually her report. It showed a negative PROphet score with a pretty low score at 1.4. And if we recall, for patients who have PD-L1 high, PROphet negative, we do know that in this preliminary data, there's improved overall survival for patients who get immune checkpoint inhibitor plus chemotherapy versus immune checkpoint inhibitor alone. And that's what this treatment considerations is getting at as well. And so for this patient, in my case at least, I would say that the PROphet score was practice affirming. I was pretty worried about how quickly the disease recurred after the resection, and then how large her lung nodules were. I did not actually show you her PET scans or her CT scans, but given how large the disease was and how rapidly I thought it was growing, I had recommended chemotherapy and immune therapy, and then I had referred her to radiation for the CNS lesion. This slide depicts where PROphet could potentially fit into our evaluation and management for patients with advanced non-small cell lung cancer starting first-line treatment. So patients, as we all know, they undergo diagnosis and staging. Often patients have most or all of this done by the time they land in my clinic. And I'm usually talking to patients about biomarker testing in my practice that includes next-generation sequencing on tissue, liquid, or both. PD-L1 testing that we do at our institution reflexively on the tissue. And then that's where I also bring in PROphet as a blood test. And then the turnaround time for PROphet, it's about 10 to 14 days. That allows for the proteomic assay to be done, that allows for the machine learning algorithm to generate the score, and then PROphet results. And around the time it results is also the same time I receive my next generation sequencing from Liquid results. And then I can use it to help guide the treatment discussion with my patients. Here, this slide depicts the pipeline. So there's a lot to come with PROphet across solid tumors. That's including melanoma, small cell, head and neck cancer. And then there's also an immune-related adverse event predictor that was recently discussed at the AACR meeting. And so a lot of exciting work here that's actively happening and more to come soon. And so my key takeaways, 80% of patients with metastatic lung cancer receive first-line immune checkpoint inhibitors. Now, as this audience is very well aware, this number varies by where we are geographically in the world and also within the country. And we know that the biomarkers we have, though, for our PD-L1 and TMB, they're incomplete predictive biomarkers. PROphet is based on proteomics of the blood to predict clinical benefit from immune checkpoint inhibitors, specifically anti-PD-1 or PD-L1 inhibitors. And as a composite biomarker, PROphet was developed to use alongside PD-L1 among patients aged 18 years and older, ECOG 0 to 2, with advanced non-small cell lung cancer to help select between guideline recommended first-line treatment options. And then this is true for any biomarker. It's also true for PROphet. It can help guide, but does not replace the clinician treatment considerations and any patient-centered treatment discussions you'll have. And so with that, I'd like to close. I'll hand the floor back over to Chris.